We are live, no, ma'am.
Okay. Very good morning. Good evening, one and all. Thanks for joining today for our journal club on infertility. This is a regular monthly webinar by OGSSI with FOGSI webinar. So I have to thank our FOGSI office bearers, Dr. Jaideep Tank, Madhuri Patel, and Charmila Ayove. A special thanks to Dr. Sureka Tayed, who is a chairperson FOGSI Clinical Research Committee. Along with this, our OGSSI office bearers, Dr. Vijaya, Dr. Geeta Lakshmi, and myself and my co-chairpersons, Dr. Priya Kanappan. Today, we have the theme of our talk is webinar is on infertility. We have a nice two journal review on reproductive medicines. And today we have our experts, Dr. Chaitanya Jnanapule, as well as Dr. Kannaki Uttaraj. So we will all start as a symbol of knowledge. We'll start with lamp lighting. Thank you. With this, I don't think so. Our Vijaya madam has joined here. And Sakiti, is
Yes,
Dr.
ma'am.
Sureka
Yes,
has
ma'am.
joined? Dr. Sureka has joined?
I'll check once, ma'am.
Okay, and hopefully Dr. Chaitanya Ganapule will join shortly. He is one of the experts. Another expert is Dr. Kannaki Madam. Kannaki Madam is a past president Cox and scientific chair ISA 2016 and UA FOGSI 2019. She had a author of a textbook of ART. She is practicing ART since 1993. She is a executive director for Tamrai Fertility Centers, almost five places in Tamil Nadu. She is an organizer for Ferticock Summit since 2002. She is a faculty of DNB program and KMCH. Madam is rightly have a Tamrai Fertility Center as well as a consultant in KMCH. And second faculty today for an expert is Dr. Chaitanya Ganapale. He is a chairperson endocrinology committee FOGSI 2024 to 2026. He is a zonal coordinator AMAX 2024 to 26. He is a director of Pearl Women Hospital and Yash IVF Pune. He is also a director of Yash IVF Hadapsar and director Satara Yash IVF, recipient of Times Health Icon 2022. He is an invited faculty and publication in national and international journals and written chapter in Jeff Cott's textbook of gynecology, FOGSI, Focus, and others. And next, we'll move on to the Kanaki Madam. Do you want to give some words about this journal club, ma'am, for the importance? Dr. Kanaki, ma'am.
Please unmute, ma'am.
Some
Yeah.
words of wisdom, ma'am.
Can you hear me?
Yeah, I can hear you.
Okay.
Yes, ma'am.
Well, my video isn't coming. That's okay. Better to hear than to see. Yeah, the Journal Club is definitely a very important facet of any organization dealing with medical science, because once we all read, I mean, it's the journal has so many chapters, and it is very difficult to keep updated on each and everything. We may not have the time, or it may not be a focus. The focus of interest may be in one area alone. So when you consider infertility, especially, there's a lot of advances and a lot of analysis. Not only advances, analysis of what has happened earlier. So I feel Journal Club. In fact, I've been nudging my people in COGS, Coimbatore, to start a journal club in OG itself. This infertility, I think, it's a very good service. And when we sit and analyze like this, a single article, somebody's taken the trouble to do a presentation on it, and we look at it from all angles, I think it's a very worthwhile effort. So congratulations to you starting this journal club. Okay.
Thank you.
Yeah.
Thank you, ma'am. We'll move on to the first journal. So moderate the session, I welcome Dr. Geeta. Geeta is a senior consultant obstetrician, fertility specialist, and laparoscopic surgeon. She's IRM Madras Medical Mission, Chennai. She did a fellowship in Craft Research Center, Kerala. She has advanced diploma in gynecological endoscopy, Germany, fellowship in advanced laparoscopic surgery, and training faculty for FNB students. Geeta, can you introduce your fellow and topic of today? Geeta? Dr. Geeta?
Yes, ma'am.
Okay.
Dr. Geeta,
Yes, yeah. So good evening, everyone. So we'll have our first journal club talk for the day. And I would like to introduce my fellow student, Dr. Swati. She's currently pursuing fellowship in reproductive medicine, very smart and intelligent. So we'll go ahead with the presentation. Swati, can I share the screen?
Yeah, thank you. We can see
Yes,
it.
ma'am.
Yes.
sorry, ma'am. Dr. Deepa, madam, sorry. Dr. Chaitanya will be he's just out of theater. He will join us maybe another 10 minutes, he told, madam.
Thank you.
Okay, thank you. So today our first talk will be on effectiveness and safety of 2 consecutive cycles of single embryo transfer compared with 1 cycle of double embryo transfer, which will be a systemic review and meta-analysis. See, though we have many different types of practice about embryo transfer, whether single, double, or more than 2, then we thought we would take and analyze meta-analysis, and then we'll have a journal club on it. So let's go ahead and start this. Swati, can we?
Yes, ma'am. Yes, ma'am. Good evening, one and all. So my topic for the day is effectiveness and safety of 2 consecutive cycles of single embryo transfer compared with 1 cycle of double embryo transfer, systematic review and a meta-analysis published in 2022 at Chengdu, China in Frontiers of Endocrinology journal. So to date, evidence regarding the effectiveness and safety of 2 consecutive cycles of SCT compared with 1 cycle of DET has been inadequate, particularly considering infertile women with different prognostic factors. So this study is aimed to comprehensively summarize the evidence by comparing 2 SCTs with DET. So there has been a progressive trend worldwide toward fewer embryo transfers since elective SCT was introduced in 2009. The ASRM data from 2000-2017 showed that proportion of SCT has risen from 5.7 to 64.2, and the percentage of multiple births among ART conceived infants has come down from 53.1 to 26.4. However, results from RCT meta-analysis and ART cycle data sets showed that the probability of live birth was reduced with SCT compared with the DET. These studies suggested that although SCT may reduce multiple pregnancies, which are highly correlated with maternal and pregnancy complications, the risk of endangering overall live birth must be considered. Evidence from a latest Cochrane meta-analysis published in 2022 indicates that compared with 1 cycle of DET, 2 consecutive cycles of SCT would be an acceptable transplantation strategy to acquire comparable cumulative live birth, while simultaneously decreasing multiple pregnancies. So this systematic review adhered to preferred reporting items for systematic review and meta-analysis, PubMed, Embase, Cochrane Library Databases, Clinical Trials, and WHO International Registry. They searched from inception till March 2022. 2 authors independently conducted study selection, data extraction, and bias assessment. RCTs and observational studies comparing the reproductive perinatal outcomes of 2 cycles of SCT with 1 cycle of DET with their own oocytes and embryos were included, irrespective of the ovarian stimulation protocol or the type of the luteal phase support. So in this study, the 2 SCT versus 1 DET was categorized into 3 types of embryo transfer cycle. So number 1 was 1 fresh SCT followed by 1 subsequent frozen SCT versus 1 fresh cycle of DET. 2 was 2 consecutive fresh SCT versus 1 fresh cycle of DET. 3 was 2 consecutive frozen SCT versus 1 frozen cycle of DET. Studies were excluded if there was a disparity between number of women and the number of cycles. Literature search showed systematic electronic literature search of the PubMed, Embase, and the RCT registries was conducted from inception till March 2022, and the bibliographies of the relevant studies were then scrutinized for any additional eligible studies. Conference abstracts and comments were not considered. So this is the flow diagram of the study selection. So according to this chart, 16,000 citations were selected through database search and clinical trial registry. After removing the duplicates, there were 13,118 studies. While screening these data, unrelated topics, unrelated comparison, articles that show donor oocyte, donor egg, donor embryo were excluded. And in comparing to the eligible criteria that didn't meet the eligible criteria, like no objective comparison, no objective outcome, insufficient data, and ineligible article type were excluded. So the final number of studies that were included were 12 studies, of which 4 were RCTs and 8 were observational studies. The outcome measures in the studies were primary outcome was live birth rate and multiple birth rate, and the secondary outcomes were multiple pregnancy, neonatal outcome complications, clinical pregnancy rate, ectopic pregnancy rate, miscarriage rate, birth weight, gestational age at delivery. So definition as per the study, live birth rate was defined as number of deliveries that resulted in one live-born baby per cycle. Multiple birth rate defined as single delivery with more than one newborn per cycle. Clinical pregnancy rate is a pregnancy diagnosed by ultrasound visualization of intrauterine pregnancy per transfer cycle. Multiple pregnancy rate was defined as clinical pregnancy with more than one intrauterine fetus per transfer cycle. Miscarriage rate was defined as spontaneous loss of clinical pregnancy before 20 weeks of gestation. The quality of the included RCT was assessed using Cochrane risk of bias tool based on random sequence generation, allocation concealment, blinding of participants and providers, blinding of outcome assessors, and other potential source of bias. Each quality was graded as low, high, or unclear risk. Other biases for which baseline characteristics were not similar, those without a priority sample size and those without an intention to treat analysis, were considered as bias. Additionally, the Newcastle Ottawa Quality Scoring Scale was used to assess the included observational studies. So they based on 3 categories like participant selection, comparability of the study groups, assessment of outcome and exposure, are graded on an ordinal star scoring scale with higher scores representing higher quality. Mantel-Hansel random effect model was used for pooling RCTs. The design-adjusted model was conducted to synthesize the results from both RCTs and observational studies in order to reduce the impact of observational study bias, to assess the possibility of impact of patient and embryo characteristics on outcomes. The study classified into 4 subgroup analysis. First subgroup was study design based on RCT and observational study. The second was a cycle type, the 3 cycle types. The third was embryo stage, whether cleavage or blast, and the maternal age were extracted separately. Coming to the results. Okay, this is forest plot analysis comparing cumulative live birth rate. So as we see here, the first set is the SCT group and the second set is the DET group, and this one is the odds ratio. So this is the cumulative result. So this states that there was no difference in the cumulative live birth rate between the SCT group and the RCT group. As we see here, we can see the diamond touching the line 1, which states that it is null. That is, there is no significant difference between both the groups. So this forest plot suggests that the cumulative live birth rate was not significant between an SCT and a DET. For the subgroup analysis, comparing cumulative live birth rate after 2 consecutive cycles of SCT and 1 cycle of DET. So here we see 4 subgroups. The first subgroup is design. The first study is the RCT type of study. So as we see here, the odds ratio is 1.09. It starts from 0.6 to 1.3. So as it touches the line 1, it states the RCT study showed no significant difference in cumulative live birth rate. Whereas coming to the observational study, the confidence interval ranges from 0.9 to 0.9, stating that it is less than 1. So it states that the odds ratio was lower, stating that the cumulative live birth rate is lower in the SCT group when compared to the DET group. Coming to the cycle type. So cycle type, first one is fresh versus fresh. As we see here, the odds ratio is 1.23. So the confidence interval ranges between 0.56 to 2.69. So as it touches the line 1, it states there's no significant difference between both the groups. Comparing fresh versus frozen, the confidence interval ranges from 0.8 to 1.1. Again, it touches the line 1. So this states that there is no difference between both the groups. Frozen versus frozen also states there is no difference between both the groups. Coming to the embryo stage. Cleavage stage suggests that there is no difference between both the groups. Coming to the blastocyst transfer, it states that the odds ratio of 1.33. So it states that the odds of having cumulative live birth was higher in the SCT group compared with the DET group. As we see, the confidence interval ranges from 1.2 to 1.3. So it is above 1. So it states that the odds of having cumulative live birth was higher in SCT compared to the DET. Coming to blastocyst plus cleavage, the odds ratio was 0.80 and the confidence interval ranges from 0.4 to 1.1, stating there is no difference between both the groups. Coming to age less than 35 shows the confidence interval ranges between 0.8 to 1.1, stating there was no difference between both the groups, and age greater than 35 also shows confidence interval ranging from 0.2 to 1.3, stating there is no difference between both the groups in age greater than 35. So in this chart that analyzes the subgroup between the SCT and the DET group, the cumulative live birth rate was less in the SCT group in observational study. And the cumulative live birth rate was higher in the SCT group when it came to blast transfer. Okay. This is forest plots chart showing us a similar subgroup analysis. So the first, coming to the study design. So the first set of study is the RCT study and the second set of study is the observational study. So as we see, this is the pooled result, that is the cumulative result. So the combination of RCT shows that there was no significant cumulative live birth between the SCT and the DET group. Coming to the observational studies, the combination of observational studies states that the odds of having cumulative live birth was lower in the SCT group compared with the DET group. Coming to the cycle type, fresh versus fresh showed no significant difference between both the groups. Coming to fresh versus frozen, there was no significant difference between cumulative live birth rate between SCT and the DET group, and the frozen versus frozen also showed no significant difference between the SCT and the DET group. So this is subgroup C, which compares the embryo stage. For the embryo stage, cleavage stage, as well as cleavage plus blast stage, the study states there was no significant difference between the SCT and the DET group. Whereas coming to blastocyst transfer, it has an odds of 1.33, stating that the odds of having cumulative live birth rate was higher in the SCT group when compared to the DET group. Coming to subgroup analysis of age greater than 35 show that there was no significant difference between the two groups. And age less than 35 also states no significant difference between both the groups. Cumulative multiple birth rate. For the 9 studies that reported cumulative multiple birth, 4 RCT and 5 observational studies, which included 197,000 participants, the overall risk of cumulative live multiple births was significantly lower in the 2 SCT group than in the DET group. And the subgroup analysis showed no differences in terms of cumulative multiple birth between the 2 consecutive fresh SCT versus 1 fresh DET and age greater than 35. So this is a forest plot chart showing us a cumulative multiple birth between the SCT and the DET group. So as we see here, the cumulative research tells us that the odds of having cumulative multiple birth was lower in the SCT group when compared to the DET group. This is a subgroup analysis comparing cumulative multiple live birth. So as we see here, first is a subgroup analysis that involves a design study, RCT study, shows the confidence interval ranges from 0.0 to 0.1. So it is less than 1. So it states the odds of having cumulative multiple birth is lesser in the SCT group. Coming to the observational study, the odds is 0.05 and the confidence interval ranges from 0.03 to 0.07, which states that the odds of having cumulative multiple birth was lesser in the SCT group compared to the DET group. Coming to the different cycle types, fresh versus fresh. The confidence interval ranges from 0.0 to 1.2. So here it touches the line 1, which states it is null. That is, there is no significant difference when compared to fresh versus fresh cycle. Fresh versus frozen cycle, the odds ratio is 0.05 and the confidence interval ranges from 0.0 to 0.1. It is less than 1. So it states that the odds of having cumulative multiple birth was lower in the SCT group compared to the DET group. And the fresh versus frozen also states that the odds of having cumulative multiple birth was lower in the SCT group compared to the DET group. Coming to the embryo stage. First one is the cleavage stage. The confidence interval ranges from 0.0 to 0.1, stating that the odds of having cumulative multiple birth was lower in the SCT group. Between the blast transfer, 0.0 to 0.2, again, the odds of having cumulative multiple birth is lower in the SCT group. Blast versus cleavage also states the same, that cumulative multiple birth was lower in the SCT group than in the DET group. Coming to the age less than 35 showed the odds of having cumulative multiple birth was lower in the SCT group than in the DET group, whereas coming to age greater than 35, the confidence interval ranges between 0.03 to 6.50. So it crosses the line 1, stating that there was no significant difference when comparing cumulative live birth rate in the SCT versus DET group. So this subgroup analysis stated that in two things. One is in fresh versus fresh cycle and age greater than 35. There was no significant difference between the two groups. Coming to the forest plot chart, the first, again coming to the study design. The RCT study stated that the odds of having cumulative multiple birth was lesser in the SCT group compared to the DET group, and the observational study also states the same. Coming to the cycle type, the fresh versus fresh cycle states that the odds of having cumulative multiple birth was lower in the SCT compared to the DET. The odds of having cumulative live birth was lower in the SCT group compared with the DET group in the fresh versus frozen cycle. Frozen versus frozen also states there was no significant difference. Coming to the embryo stage, all the three embryo stages states that the odds of having cumulative multiple birth was lower in the SCT group compared to the DET group. Coming to the age classification, age greater than 35 showed no significant difference between both the groups, but age less than 35 showed the odds of having cumulative multiple birth was lower in the SCT compared to the DET. Coming to secondary outcomes, there was no difference in the cumulative clinical pregnancy rate, ectopic pregnancy rates, miscarriage rates were noted in the SCT compared with the DET group. But the cumulative multiple pregnancy rate after 2 SCT was significantly lower than 1 cycle of DET. There was no significant differences in respect to cumulative GDM or preeclampsia. And additionally, there was no difference in regard to APGAR score, perinatal mortality, macrosomia, birth defects. Whereas the cumulative preterm birth rate, low birth weight rate, NICU admission rate, APH and cesarean section rate, they're significantly lower in the 2 SCT groups. And we also noted a longer gestational age at birth and the higher birth weight were found in the 2 SCT groups compared with the DET group. So coming to the discussion, in the systematic review, 12 studies were taken and the sample size was 1,98,000. Participants comprising of 40,000 women underwent 2 consecutive SCTs and 1,58,000 women underwent 1 cycle of DET. Study participants were from USA, Europe, and Asia. 10 studies used 1 fresh SCT, 1 subsequent frozen SCT versus 1 fresh DET. 1 study used 2 consecutive frozen SCT versus 1 frozen DET, and 1 study used 2 consecutive fresh SCT versus 1 fresh DET. 5 studies had cleavage transfer, 3 studies had blast transfer, and 4 studies had both. All RCTs reported randomization method. 2 conducted blinding for participants, 2 observational studies were prospective cohort, other 6 were retrospective cohort. This systematic review showed that 2 consecutive SCT compared with 1 DT resulted in a similar probability of cumulative live birth, but enormous decreased risk of cumulative multiple birth. In the subgroup analysis, cumulative live birth significantly increased after 2 consecutive cycles of single blast versus 1 cycle of double blast transfer. Improved maternal pregnancy and neonatal outcomes were found in the 2 SCT groups. The probability of cumulative live birth following 2 SCT was about 97% of that achieved by 1 cycle of DT. However, the risk of cumulative multiple birth after 2 SCT was about 5% compared with DT. The risk of cumulative preterm low birth weight were about 1/3, 1/5 compared to DT. This study suggests that using 2 SCT strategy results in comparable cumulative live birth regardless of the embryo stage. But more live births can result with 2 consecutive cycles of blast transfer while concurrently decreasing multiple live births. The study findings suggest that younger women aged less than 35 years may benefit from 2 SCTs since it has a lower multiple birth compared with DT. Oocyte aneuploidy and decline in the uterine receptivity in older women may recommend a multiple embryo transfer. Due to higher risk of adverse pregnancy outcome associated with advanced age, the safety of 2 SCT versus DT should be thoroughly evaluated. So, comparison with the previous studies, one Cochrane meta-analysis published in 2022 investigated the efficacy of 2 SCT versus DT. The overall effects of cumulative live birth were comparable in both studies, while safety indicators were not included. Subgroup analysis based on embryo stage found cumulative live birth increased 33% after 2 consecutive cycles of single blast compared with double blast, while only cleavage stage transfer was included in the previous study. So the strengths of this study, this meta-analysis conducted various sensitivity analysis to ensure the robustness of the finding. Additionally, one of the most comprehensive outcome assessment of 2 SCT versus DT conducted to date, as it includes many previously unreported adverse outcomes associated with ART treatment, pregnancy, and childbirth. This provides more evidence for both healthcare professionals and patients. Furthermore, observational studies with diverse population and larger sample size were included. Conducting subgroup analysis of important prognosticators that have been rarely been involved in previous studies can be useful for identifying subpopulation that would benefit from each strategy. Limitations of the study, male factor, ovarian reserve, maternal BMI are other important prognostic factors that have significant impact on the outcome. Unfortunately, although the baseline distribution of the above indicators were reported in the originally included studies, no further stratified analysis were performed, which limited the secondary analysis. Significant heterogeneity was present for some sensitivity and subgroup analysis. The sample size was insufficient for some of the subgroups. Maternal and neonatal outcomes such as cycle type, GDMP, NICU admission rates. The relatively small sample size may limit the power, and thus the capacity of our study to identify a true difference should be interpreted with caution. According to the current evidence, the 2 SCT strategy is associated with a similar live birth rate and better obstetric and neonatal outcomes compared with 1 cycle of DT. Subgroup analysis also showed some characteristics of patients and embryos with critical prognostic factors regarding the reproductive outcomes of ART. Differences in cumulative live birth was witnessed in patients who underwent 2 consecutive cycles of single blast transfer. Non-significant cumulative live birth and significant lower cumulative multiple birth were found in the subgroup analysis of patient aged less than 35, which suggests that infertile women aged less than 35 and those receiving blast transfer would benefit more from 2 consecutive SCT strategy. Further, high-quality RCT or National Registry-based cohort studies are needed to confirm these findings and to assess suitable transplantation strategies for infertile women with other prognostic characteristics. Summary: there was higher risk of adverse maternal and perinatal outcome in twins conceived through ART as compared to twins conceived naturally or through non-ART methods. Two consecutive SCTs resulted in similar cumulative live birth as compared with one DET, while decreasing the risk of multiple pregnancy. The two SCT strategy is associated with similar live birth and better obstetric and neonatal outcomes compared with one cycle of DET. ART twin pregnancies should be recognized and managed as higher risk group. Additionally, women seeking assisted reproduction should be counseled regarding the increased risk of ART twin pregnancies. Thank you. Thank you so much.
Thank you, Swati. I take an opportunity to welcome our expert, Dr. Chaitanya, Chairperson, Reproductive Endocrine Committee of FOGSI.
Good evening, everyone.
Well,
Sorry for joining a little late.
No.
Just came out of the theater or OT.
No problem. Thanks for joining.
Yeah.
Okay. Dr. Geeta,
Yes, sir. Yes, ma'am. Yes, ma'am.
so would you like to highlight her
Yeah.
points?
We'll have some discussion on this. So, Swati,
Okay.
can you tell in crisp about leave away with the subgroup analysis about the RCTs or observational studies in the meta-analysis? For a carry-home message from this article, what would you suggest? When you compare two SCTs and one double embryo transfer regarding live birth rate, what do you say?
Ma'am, in this study,
Yeah.
we see
Yeah.
in this study we see that in one point where they had undergone a blast transfer, they say the cumulative live birth was good compared in the two SCTs compared to the DET group.
Okay, so overall, is it like they say it is the same live birth rate, right? Or cumulative live birth rate?
Compared in summary, they say the probability of
Similar.
cumulative live birth was similar in both the groups. But when they
Yes.
did a subgroup analysis, comparing the embryo stage, the cycle types, one particular place where they did a blast transfer between the two groups, they say that when they the SCT group had a higher live birth rate in a blast transfer, two consecutive cycles of blast versus one cycle of double blast.
Okay. Can you, we wanted to know about the place where they also compared cleavage and blast, right? So
Yes,
what was
ma'am.
the analysis on that? So when they compared the cleavage state to single embryo transfer and the blast to single embryo transfer, what was suggested at the end?
Ma'am, in cleavage stage, totally 15,499 events had taken place, out of which in the SCT group, they were only positively, only 9,000 samples have been positive. Whereas in the DET group, 7,000 people have underwent cleavage stage DET, out of which there was only 67,000 of people who have had a positive event. So it shows there is no difference in the cleavage stage transfer. And again, when comparing blast and cleavage stage, so how they have done the blast and cleavages, they have done one cycle of cleavage transfer, followed by consecutive cycle of blast transfer versus a double cleavage transfer or double blast transfer. So that's how they have done one study, one subgroup study. In that also, they are mentioning that there was no difference in the statistical analysis between both the groups.
Okay. Regarding age, what is the take-home message according to the meta-analysis? Less than 35, more than 35.
Ma'am,
So
there was a
HCT
positive cumulative live birth between both the groups.
Okay, so when less than 35, is it okay to go ahead with double embryo transfer or two SCTs? What was that suggested at the end?
They say that age less than 35 with the blastocyst transfer may yield good pregnancy rates. Single live birth rate may be good.
Okay. So what do you suggest? Overall, two SCTs is better or double embryo transfer is better?
Ma'am, it depends. We can individualize our patients. Suppose if we have a patient of lesser age group, like less than 35, and they've had a previous positive IVF pregnancy, and if they have a good quality embryo, I think going in for two cycle of SCT would be a better choice to reduce the multiple pregnancy rates and the preterm deliveries and NICU admission rates.
Okay.
So we can individualize according to the patient profile, ma'am.
Okay, so there was an other subgroup analysis where they compared fresh versus frozen, right? Fresh, two single SCTs with a frozen DET and all. So overall, what was the only significant thing which we found in this meta-analysis? Just highlight the significant one, because you were talking about everything, no odds ratio. Just tell me
Ma'am,
only
you're
that.
asking about a cumulative multiple birth or live birth, ma'am?
Live birth. Tell me live birth first.
Ma'am, live birth, all the three cycle types like fresh versus fresh, fresh versus frozen, frozen versus frozen had a similar cumulative live birth.
Okay, and whereas in
Whereas in cumulative multiple birth, except fresh versus fresh, that is the other two frozen, fresh versus frozen and frozen versus frozen, showed that the cumulative multiple birth was lower in the SCT group compared with the DET group. Only in fresh versus fresh transfer cycle, the cumulative multiple birth was similar in both the groups.
Okay. So, see, overall, the carry home message would be better cumulative live birth rate with 2 SCTs rather than going with double embryo transfer. And the other thing is, like, including all the obstetric and perinatal outcomes with multiple pregnancy, it is always better to go with 2 SCTs.
Single embryo. Yes, ma'am.
Yeah, 2 single embryo transfers.
Yes, ma'am. Until date, this was one of the largest study with a diverse population, ma'am. They included patients from USA, Europe, Asia. And this was one of the study with, I have seen recent studies and the Cochrane meta-analysis also. It involves subgroup analysis such as the cycle type, embryo transfer and all those things. So I think this study is and also it's a systemic review and a meta-analysis which holds strongest scientific evidence. So I think 2 SCTs would be better when comparing the multiple pregnancy, low birth weight, preterm deliveries, and cesarean section rates, ma'am.
Okay. So everything included their own oocytes, right? In this whatever
Yes,
study.
ma'am. They excluded donor oocyte, donor egg, ma'am. They included only own oocytes, own embryos.
And there were no study which included more than 2 embryo transferred.
No, ma'am.
Okay. Sorry, I have a one question, Geeta. Okay, having this world of fast track, so you said the cumulative birth rate is fast, equal in both the things. So, how will you counsel for the patients for the two? It was a slow progress, right? 2 SCT, but in DET it's a fast track. We can have one shot, we can put 2, and then the rate of pregnancy is high, same, right?
Yeah, ma'am. Ideally, we need to individualize patient in counseling them. Number one, going with the age first and with the available embryos, and depending on the quality of the embryos they have. So if we have a good blast, we can even go with single embryo transfer, provided she's a younger age and even in a older age, I would say. But if we have, if it is not a blast and if the embryo quality is average, going ahead with double embryo transfer would be fine. This is like overall, I'm giving if at all we need to analyze whether to go with single or double. But always double embryo transfer, we do have the risk of multiple pregnancy. We need to counsel before transferring 2 embryos or whatever, and then we need to go ahead with that.
Dr. Geeta, if your patient specifically asks, I want twins. There are many patients who come and ask you.
Yeah. Then in that case, we need to counsel and we can go ahead with 2 single embryo transfer, meaning 2, a double embryo transfer at a stretch. If she has embryos, then in that case, it is patient's option. If they are willing and they want, then we can give them twins.
Okay. So, Deepa, can we ask our experts, Deepa Madam, if that is?
Yeah. So a couple of things what I would like to say here is that if I've joined a little late, so I couldn't go through the entire paper what she presented. But out of the 12 or 13 studies which have been taken for the meta-analysis, of that 10 have compared first fresh, second frozen in the single embryo transfer versus one frozen double embryo transfer. Am I right?
Yes, sir.
Yeah. So here itself, there is a little bias in this, because I would suggest if you have to compare 2 groups, you have to compare either fresh to fresh or frozen to frozen. So majority of the studies which have been taken here have got a bias in it, and inherent bias which is there. So we have to keep this in mind when we are actually taking the outcomes out of this entire meta-analysis. So maybe it would have been better if we do a frozen to frozen or a fresh to fresh transfer. But all said and done, now lately there are quite a few papers which are presented which says that fresh embryo transfer is equally good as compared to frozen embryo transfers. So it all started with fresh embryo transfers till the time we didn't had a very good frozen freezing program. Once the freezing program was in place, there were a few years wherein all of us were saying that frozen embryo transfers will give us better results as compared to a fresh transfers. Again, now we are coming back to individualization and not blanketly saying that frozen embryo transfer for all, right? There was a phase in between where we used to say freeze all policy for each and every woman, right? Now we are again saying that individualize it, go where you want to avoid OHSS. That's the time, that's the segment of patients where you should be going for frozen embryo transfer, but otherwise you can individualize. So that's one thing. And as Dr. Geeta said, Deepa, I would like to say that counseling becomes very important in the entire process, right? So if we are saying that you can wait for a couple of months, but you can have less number of multiple births, and the problems, perinatal problems which are associated with the multiple births, many a times the couple would opt for going for 2 single embryo transfers rather than going for double embryo transfer. But it will take a little more time for them to conceive or achieve pregnancy. So time to conceive will increase, but probably the take home baby rate might increase. One. Number two, the overall cost is going to be less, because if you consider the perinatological issues and the cost which is associated with, say, for example, low birth weight babies, preterm babies, and NICU admissions for those, then overall probably somewhere the cost will also go down if we are going ahead with 2 single embryo transfers rather than going ahead with a double embryo transfer.
Thank you, Dr. Chaitanya.
Kaniki,
Kaniki, ma'am.
Thank you.
Ma'am, you're muted, madam.
Ma'am, Kaniki,
Ma'am,
ma'am.
yes.
I'm here. Crystallizing the whole thing. Basically the pregnancy depends on two things. One is the embryo, the genetic quality of it, and the endometrium and the implantation window, right? So the live birth rate directly is dependent. So age will be an important factor. And when you do, when you take them to the blastocyst, you're already weeding out the bad embryos. So that is one thing. And therefore, what reaches blastocyst is probably a very good embryo. And putting one of them would make more sense than putting two of them and getting on your with multiple pregnancy. So that makes a lot of commonsensically, if you look at it, take it to the blastocyst and freeze it singly and put a single embryo. And also, when you're doing it in 2 different cycles, the endometrium, you can improve it. If it was not that good, you could do something in the second cycle. If you detect something in the first cycle of the single embryo, you still have one more embryo to try it with a better protocol. So in all ways, taking to the blastocyst and putting it in the single embryos would definitely, all of us know how drastic a twin pregnancy can turn sometimes with its complications, especially if she's an IVF thing, she's conceived, gone there, and then if she's going to lose it because of multiple pregnancies, it's going to be very sad. So definitely single embryo and take it to the blastocyst. The other thing, when you do 2 embryos, double embryo transfer with cleavage, you really are not sure of the embryo quality. That's one thing we have to bear in mind. Yep.
Deepa
Thank you,
ma'am.
ma'am. Thank you, ma'am. Okay. With this, Priya, shall we move on to the next talk? Thank
Yes,
you
ma'am.
so much, Geeta and the team.
Thank you, ma'am. Thank you, ma'am.
Priya,
Yes. It is my pleasure to introduce Dr. Mona Pandurangi Madam. Madam is MD Obs-Gyn, Associate Professor, Department of Reproductive Medicine and Surgery, Srihar, Chennai. She's a member of the Tumor Board of Srihar, Chennai, special interest in Doppler and fertility preservation. And she has various publications in National Journal. And anyone who's interested in fertility, she would have known her in many conferences. So we are like, a much awaited topic from your side, Madam. So, ma'am, can you
Thank
introduce
you.
your fellow women?
Yeah, thank you, OGSSI, for giving this opportunity to our institute and me and Dr. Namita. Namita is our MCH second year postgraduate in reproductive medicine and surgery. And I would appreciate that she readily agreed to present this topic or choose this topic, though the time was short. So, Namita, can you? And actually,
Yes.
we chose this topic because unexplained infertility is very commonly, I mean, you see it in general practice, okay? And with more and more of investigations coming up for recurrent implantation failure, people are now have a tendency to apply it even for, unexplained infertility. So how much to investigate to say that she is an unexplained infertility before labeling her? And what would be the treatment protocol we need to follow? And how much we would want to make her spend before we go in. So we thought the recent ESHRE guidelines has come up into 2023. We thought we can discuss this and so that it will be beneficial for all the OG practicing gynecologists, okay? And what to do and what not to do. Namita, you can share the slides. Dr. Namita.
Thank you, ma'am.
Yes,
Yeah.
doctor, we can see your screen. Go ahead.
Namita? Dr. Namita? Namita, we can't hear you.
We can't hear you.
Namita?
Good evening, everyone. As it, just a second, ma'am. Can you hear me now, ma'am?
Yes.
Yeah, better.
Yes. Do you have a like a good connection? Then you can even show your video. It'll be nice to see the presenter if that's okay.
Ma'am, actually, because of the connectivity issue, I have
No
off the video,
issues.
ma'am.
No
Yes,
problem.
ma'am.
No problem. Go ahead, doctor. Go ahead.
So coming to introduction, briefly on unexplained infertility. Unexplained infertility, it's actually a diagnosis of exclusion, wherein we don't find any abnormalities in female and male reproductive system based on the standard investigations. And the prevalence of unexplained infertility is 30%. A consensual standardization of diagnostic workup is still lacking for unexplained infertility, and the existing guidelines of unexplained infertility were released by Canadian Fertility and Andrology Society in 2019 and from ASRM in 2022. But both these guidelines were focused mainly on the treatment of unexplained infertility. So hence, the ISHRE guidelines focused both on diagnosis as well as treatment of couples with unexplained infertility. So we have the following factors which cause infertility, that is the ovarian factor, tubal factor, uterine and pelvic factors, cervical factors, and male factor. So in unexplained infertility, we see that there is no abnormality detected in any of these factors. So how would you want to evaluate these factors? Before going to evaluation, what is the definition? According to the International Committee for Monitoring Assisted Reproductive Technology, this defined that infertility in couples with apparently normal ovarian function, fallopian tubes, uterus, cervix, and pelvis, and with adequate coital frequency, an apparent normal testicular function, genitourinary anatomy, and a normal ejaculate. So the same definition was included in ISHRE 2023. They just added the age parameter, that is the age they have defined as less than or equal to 40 years. Rest all definition stays the same. So before diagnosis, the guideline recommends a thorough history taking, which is most important.
of medical, reproductive, and sexual history, not only from the female partner but also the male partner. Because we usually don't concentrate on the history taking of the male partner, but this guideline refers that history taking should be taken both for female and male partner. Coming to the ovarian factor, so we all know what are the tests for ovulation. That is the menstrual history, most commonly done ultrasound, LH ovulation kits, basal body temperature, progesterone, serum progesterone evaluation, or the cervical mucus examination. Among all, so do we really need to do the to confirm any test to confirm the ovulation for diagnosing unexplained infertility? The guideline states that in a woman with regular menstrual cycles, testing for confirmation of ovulation are not routinely recommended. So, what is a regular menstrual cycle? A regular menstrual cycle is between 24 to 38 days, up to 8 days in duration, and the shortest to longest cycle variation is less than 7 to 9 days. So, the guideline says that it is in a regular menstruating female, you don't need to confirm the ovulation, but if at all it is ovulation test is warranted, then any of the following methods told before can be done. Most commonly, everyone does the ultrasound monitoring. So what about the quality of oocyte or corpus luteum? Do we need to test the quality? Uh, the guidelines state that in a regular menstrual, if a woman is having regular menstrual cycle, it is not suggested to routinely measure any mid-luteal serum progesterone levels to confirm ovulation or the quality of corpus luteum assessment or oocyte quality assessment. And it is also not required to do any endometrial biopsy for histological examination to confirm in the absence of any other indication. So coming to the tubal factor, the following tests are available for tubal testing, that is HSG, HycoC, both with contrast or saline, and laparoscopy with perturbation, and even now the chlamydia antibody testing. So what does the guidelines say? The guidelines said that say that HycoC and HSG both are valid tests for tubal patency when we are comparing laparoscopy to chromoperturbation, which is a strong recommendation. So, what do we do? Either HSG or HycoC, which one is preferred? So, the guidelines say that both are comparable in diagnostic capacity, and the selection of the technique depends on the preference of the clinician and the patient. Though more commonly now people are moving towards HycoC from HSG because of the advantage of having even we can evaluate the pelvis also, and also they have no exposure to any radiation. So that's why people are moving towards HycoC now, but both have equal diagnostic capacity. And what is this chlamydia antibody testing? So chlamydia antibody testing is a non-invasive method wherein we test the antibodies for chlamydia in the serum by ELISA method. So is this test equivalent to other tubal patency test? So the guideline clearly states that chlamydia antibody testing, it can be used for tubal patency only to differentiate between low and high risk patients for tubal occlusion. So if in this test we find out that it is at high risk for tubal occlusion, then they recommend to have a visual demonstration of tubal patency because of the fact that even though the sensitivity of this chlamydia antibody testing is between 0.2 to 0.9, but still we cannot depend on the assays which vary. Also it doesn't give the exact site and location, or we cannot 100% say that there is no problem with the tubes. Next, coming to the uterine and the pelvis factor. So what diagnostic approach would you go? There are following modalities of diagnosing, that is the ultrasound, 3D preferred more than 2D, HycoC with 3D, MRI and histoscopy. According to ISHRAE, ultrasound preferably 3D is recommended to exclude uterine anomaly in women with unexplained infertility, which is a strong recommendation. And MRI is not recommended as a first line. When we have a 3D ultrasound, MRI is usually not recommended. And if ultrasound assessment of uterine cavity is normal, no further evaluation is needed. So should we do laparoscopy to diagnose unexplained infertility? The guideline clearly states that routine diagnostic laparoscopy is not recommended for the diagnosis of unexplained infertility, which is a strong recommendation. So when do we have to do this histolaparoscopy? So whenever we are seeing any abnormal HSG or any clinical symptoms of PID, or we are suspecting on examination any PID or previous ectopic pregnancy history, and in clinically we suspect or we diagnose endometriosis based on ultrasound findings, in 2D ultrasound findings, where we see both the ovaries are stuck behind the uterus, or when we are doing the sliding sign which is negative. So these points towards any pelvic pathology. So that time we need to do laparoscopy. But it is when we diagnose this, we suspect or diagnose this pelvic pathology, it is no longer unexplained infertility. So the cervical factor. So do we need to test for this cervical factor, such as a postcoital test or this vaginal microbiota? The guidelines say that the postcoital test is not recommended in couples with unexplained infertility, which is a strong recommendation, because the cumulative pregnancy rate are similar after this postcoital test, whether it is positive or negative. The pregnancy rates is the same, and it being an invasive test, and this won't change any further management of the patient. So this test is not recommended anymore. What about vaginal microbiota? The current evidence is insufficient to tell the role of abnormal microbiota in unexplained infertility. So it is still only in research purpose. Coming to the male evaluation, uh, after history and examination, if we don't find any abnormality, the only investigation they recommend is a a semen analysis. According to WHO 2021, the sixth edition, fifth centile data is used for the lower reference. And if this investigation is normal, further we'll be telling what further to be done. So if we see the WHO has abnormal semen analysis, then we still cannot categorize them as unexplained. We have to wait for another abnormal reading after 3 months. So only if two semen analysis abnormal, then we can categorize them as a male factor responsible for infertility. Otherwise, it will still go under unexplained. What about the additional test? Do we need to do them after a normal WHO semen analysis parameter? The tests such as testicular imaging or an anti-sperm antibody testing in the serum, sperm chromatin condensation test for DNA fragmentation index, and sperm aneuploidy screening or any hormonal testing, and HPV testing in semen, or any microbiology testing of semen such as semen culture. These all tests are not recommended according to the guidelines. Uh, the justification behind this is the insufficient evidence for the benefit of this test, especially in patients with normal semen analysis. There is no data which is suggesting that it can be beneficial. What about the other systemic causes in patients with unexplained infertility? Do we need to do, such as antibody testing for anti-sperm antibodies, female coelomic diseases, thyroid antibodies, and thyroid hormone levels, and thrombophilias, oxidative stress test, genetic tests such as karyotyping, or vitamin D deficiency testing, testing, and BMI. Out of this, the thyroid hormones and the BMI is recommended. It is uh, advised. BMI, because it is not associated with unexplained infertility directly, but it has an impact on the spontaneous conception rates. So hence, they have advised to about this parameter. And about the thyroid hormones, they are saying that TSH measurements is considered as a good practice in preconceptional care, and no other thyroid evaluation is recommended in patients if TSH is within normal limits, which is a strong recommendation. So, the testing for ovarian reserve, is it really necessary for diagnosing unexplained infertility? So, in women with regular menstrual cycles, ovarian reserve testing is not required to identify the etiology of etiology of infertility, or to predict the probability of spontaneous conception over 6 to 12 months, which is a strong recommendation. So they are saying that as long as uh, they maintain regular menstrual cycle, women with decreased ovarian reserve seems to have similar spontaneous pregnancy rates with women of similar age who have normal ovarian reserve. So hence they are saying that just for a diagnostic stand of point, ovarian reserve test is not required. So in the treatment, The treatment options available are expectant management and active management. Under active management, we have ovarian stimulation with timed intercourse, natural cycle IUI, ovarian stimulation with IUI, and IVF. So expectant management. What is this expectant management? So the patients with unexplained infertility do not have any cause. So we can wait, whether we can wait for them to have spontaneous conception. If we can, for how long can we wait? And what are the prognostic factors? So the guidelines say that there are following prognostic factors, that is the age, duration of infertility, previous treatment, and previous pregnancies history. So these form with these prognostic factors, there are different prognostic models, and these models can help. They give a score. So based on the scoring, they can be classified as good prognosis and poor prognosis. And based on this, this can help in decision making of on the treatment plan for couples with unexplained infertility. But the present guidelines say that none of the currently available predictive models are fully evolved, and more evolved dynamic models have to be provided, uh, uh, which can provide the estimate of the chance of natural conception over 6 to 12 months. Have yet to be These have yet to be validated and implemented. But in the end, the guideline is saying that, however, it is also important to take patient preferences into account whether deciding on the treatment options. So, whether we want to go from expectant management or we want to go to active management should depend on the patient preferences also. So now I'll be just comparing few studies wherein they have compared any sort of active management with expectant management under expected management parameter. So when they have compared clomiphene citrate with timed intercourse with or without ovulation trigger versus expectant management with the following RCTs, they have quoted that there is no benefit. So there is no difference. So whether you are doing expectant management or you're doing clomiphene citrate with timed intercourse, there is no difference in the pregnancy rates. So hence clomiphene citrate with timed intercourse is not recommended as an active management for unexplained infertility. What about natural cycle IUI versus expectant management? That is also saying that there is no benefit, and hence natural cycle IUI is not recommended as an active line of management when we are comparing with the expectant management. What about ovarian stimulation with IUI versus expectant management? There we can see there is a benefit with odds ratio of 4.48 in a systemic and meta-analysis. So hence they have come to a point that ovarian stimulation with IUI is recommended over expectant management for unexplained infertility. They're saying that it is a first line management for couples with unexplained, and the decision to start active management should be based on the prognosis in couples with unexplained infertility. So if you're going for active management, what type of active management? And is there any variation in the ovarian stimulation with timed intercourse? So when we're comparing different ovulation stimulation drugs, oral and gonadotropin also versus ovarian stimulation with IUI, ovarian stimulation with IUI is having a higher live birth rate, and it is recommended over timed intercourse. And if we are doing IUI, ovarian stimulation IUI is still better than natural cycle IUIs. Hence, they have told that ovulation induction with, ovarian stimulation with IUI is recommended as a first line treatment for couples with unexplained infertility. To avoid multiple pregnancy and OHSS, care needs to be is needed when we're using gonadotropin treatment, and it should be usually used in a low dose regime with adequate monitoring. Previously, in ASRM guidelines, they have not recommended to use gonadotropins, whether conventional or low dose. But in this guideline, they have told that you can use it, but you have to use low dose regime with adequate monitoring. They have also suggested that we can do IUI up to 3 to 6 cycles, wherein previously they had suggested in ASRM, which was 3 to 4 cycles. So now coming to IVF, when do we have to go for IVF or IUI? When we have compared direct IVF with ovarian stimulation, there is no benefit if the age of the female is less than 38 years. So when we're comparing ovarian stimulation with IUI versus IVF, ovarian stimulation is still recommended as a first line over IVF in a female less than 38 years. When do we want to do a direct IVF? So in a female who is more than or equal to 38 years, that time going to IVF, the meta-analysis have shown a live birth rate higher compared to ovarian stimulation with IUI. So the direct IVF may be beneficial after the age of 38, but it still needs to be individualized based on the patient characteristics. IVF is not probably recommended over IUI with ovarian stimulation in couples with unexplained infertility. It is expected that the decision to use IVF is individualized based on patient characteristics such as age, duration of infertility, previous treatment, and previous pregnancy. ICSI is not recommended over conventional IVF in couples with unexplained infertility, which is a strong recommendation because there is substantial evidence from previous RCTs that there is no difference in the live birth rate between IVF and ICSI for non-male factor infertility. What is the value of other mechanical and surgical procedures? So, hysteroscopy for the detection and possible correction of intrauterine anomalies which are not seen at routine imaging is not recommended, which is a strong recommendation. HSG, that is tubal flushing with an oil soluble contrast media, is preferred over water soluble contrast media. But the risks and the benefits of tubal flushing with oil soluble contrast media should be discussed with all the couples with unexplained infertility, which is conditional. Uh, and also, endometrial scratching should not be offered for unexplained infertility, which is a strong recommendation. What about other alternative therapies, such as oral antioxidants in both male and female are not recommended, and acupunctures are not recommended, and inositol supplementation for unexplained infertility is not recommended. So what is recommended is psychological support, including psychotherapy, is recommended for patients when needed. A healthy diet and regular exercise supported by behavioral therapy when necessary are recommended. So when we critically analyze the ISHRAE guidelines, out of the 29 strong guidelines, most of the recommendations were based on moderate to low to very low quality evidence. That is, out of 29, only one strong evidence was based on a strong recommendation was based on moderate. Rest 9 were low, and the remaining were very low quality. And prognostic based active management was not included or not recommended in this guidelines. Just to summarize the ISHRAE guidelines that is under investigation. So for a female, regular ovulation, only menstrual history is enough. And to see a normal uterine cavity, 3D ultrasound is enough. And to see the patent fallopian tube, HycoC or HSG can be done. And if you're doing chlamydia antibody testing, then that has to be confirmed by visual method. And for a male, normal semen analysis according to WHO criteria. For management, we have to consider the prognostic factors, and if it's a good prognosis, expected management for 6 months can be done. And if that fails, then ovarian stimulation with IUI, and even for poor prognosis, ovarian stimulation with IUI can be done for 3 to 6 cycle. If that fails, then IVF can be done. And for patients with more than 38 years, they're saying we can go for direct IVF. And additional care such as healthy diet, regular exercise, behavioral therapy, psychotherapy can be given. So the take-home message, the diagnosis of unexplained infertility is a diagnosis of exclusion. No role in routine diagnostic histolaparoscopy. Expectant management should be individualized based on the prognostic models. First line management should be ovarian stimulation with IUI, 3 to 6 cycles. Direct IVF is not recommended in less than 38 years. IVF use should be individualized based on patient characteristics. Thank you.
Thank you, Namita, for excellently discussing in a short time the whole, I think, almost 100-page article which has come. So, apart from very nicely summarized, you gave some summary of take-home points. Any other 2 points you would want to say the take-home points. Any other regarding, say, ovarian stimulation? Anything you want to say? Like with IUI, without IUI, what is commonly practiced, and what the guideline says that it may not be very beneficial.
Ma'am, actually, if we are doing multiple cycles of ovarian stimulation with clomiphene citrate or letrozole, it might not be that beneficial as like it is as equivalent as expectant management. So we better do ovarian stimulation with.
Yeah, very true. So most often we see patients coming with files of report where, you know, number of times they have received clomiphene citrate, aromatase inhibitors, and few cycles maybe with gonadotropin. So the evidence says that it is not beneficial because they are already ovulating, and that's a big take-home point. And by that time, patient is exhausted, and then they come for further treatment. I thought that's the thing. And anything else? I had few things which I want to put across the expert panelists, sir. Before that, sir, can you, would Dr. Chaitanya, sir, or madam tell their few points on this presentation?
Very nicely summed up by Dr. Bellard. It's quite a vast guideline which has come from Ishre. So she has summarized it very nicely. One thing what the ASRM is telling a little differently than what Ishre is saying is about IUI. ASRM clearly in its latest, it's 4 years old. 2020, they had come up with an guideline regarding the unexplained infertility, where they say that IUI with gonadotropins should not be used for treating unexplained infertility because of the unacceptable higher rates of multiple pregnancies. That is what they had recommended in their latest guideline, which is a little different from what we are seeing in this Ishre guideline. Rest all, I think, more or less, they are comparable to each other.
Okay, sir. Madam Kanagi, ma'am, you have anything?
Yeah, just a few points. The whole management is should be focused on the age of the patient. If she's a younger patient, she can be given a lot of time. They say even up to 3 years you give her, if she's within a year, up to 2 to 3 years. And the younger patient with normal parameters, normally they fall. But the patient psychology is they cannot wait, especially in a society like ours. There's often a need for doing some kind of treatment. You have 20-year-olds married 3 years coming for treatment, so there are a lot of issues. You have to factor in the society and their psychological thing also.
So ma'am, do you say that there is a place for clomiphene citrate with follicular monitoring and normal relationship? I would not say time relationship. So is there a place in young patient like that who come, like the recommendation
young patients, you can definitely, there is a place. You do see a lot of them conceiving with simple 5 tablets of letrozole or clomiphene. You do see them,
but they may be anovulatory. Like in an ovulatory patient,
the basis of an unexplained infertility. What is wrong there? The thing is what we cannot see. There is something wrong, but we cannot see it. That's the bottom line of unexplained infertility. And what could be wrong? It could be the genetics of the oocyte. It could be a fertilization issue. It could be an implantation issue. All these we have no insight into. So we try to boost the egg. We try to boost the sperm. And we try to give a better environment for time it. We do all the facilitation, and that's what ovulation induction and IUI is about. We are trying to boost the gametes as well as providing them their meeting at the right time and providing a right atmosphere for fertilization and implantation, supporting with progesterone and so on and so forth. So we're trying to, better every aspect of the whole process. And see, my take on unexplained, when the semen factor is normal, when the male is absolutely normal, it is usually an oocyte defect. We all know that not all the oocytes in the ovary are genetically capable of becoming a baby. So it's only about 10 to 20%. And in each cycle, which population comes up, whether the good one or the bad one or the bad population, we have no control. And that is why you see with all our gonadotropins, we may not get a pregnancy, but in the next cycle, she becomes pregnant by herself. So we don't have control over the choice of the oocyte to come up in that particular cycle. So that's one thing we have. Similarly, we don't have a choice of which sperm combines. We have only 4% of the sperm population being normal. So even an abnormal sperm can fertilize, but cannot take it up to a pregnancy. So only if this one of the 4% and one of the genetically normal oocytes, if they come together, we get the pregnancy. And this is what we have to understand when we counsel them for unexplained IUI or IVF. Very often we are not able to give an explanation, and probable explanation is this. That's one thing.
Right.
And the
Yes, continue.
sorry, there was something that went wrong. Yeah. The other thing is regarding the use of gonadotropins, there was a nice study by the Mayo Clinic. What would be the best thing in an IUI program, which will give you best results? And they came up very clearly with the fact that use of gonadotropins definitely gives a better result. I mean, of course, there is a
Actually,
result.
this article,
That's a very nice study by the Mayo Clinic. And the results are influenced by two factors. One is the age of the patient, the lady, and the second is the post-wash motility. If the post-wash motility is more than 70%, then you get better results. Similarly, younger age, that we all know, younger woman, she will give you better results. But using clomiphene in an older woman, especially if the husband's sperm has less than 70%, there's no point in doing that program. So in the older women, gonadotropins, and of course, wash the sperm and see if you can get a 70%.
So this guideline was, I think, made in general so that keeping the cost also in mind. They said this guideline says you can use gonadotropin, but then the cost and the risk of multiple pregnancy and the monitoring which would go in if you want to prevent multiple pregnancy. That was
They have all the national programs, so they have to work out the cost for the whole scheme, rather than unlike us where it's mostly private care.
Yes,
so that's
and we also need to take our societal pressures and everything also into consideration when we are offering any kind of treatment. That couple would be better off having a twin pregnancy rather than not having a pregnancy at all. So if you discuss all these things, they will say, boss, I want a pregnancy. You give it whatever way you can. So I'm not bothered whether I'm pregnant with one baby, or I'm pregnant with couple of babies, or even more than that. So somewhere we have to balance out everything, what comes out as a guideline everywhere, and what can be practiced in the scenario where we live. So we have to consider all these things together.
Exactly, that we have to factor in. We also have to factor in that if these guidelines were strictly followed, many of the ART clinics will not have to be functional.
Absolutely.
One more question. So this guideline says...
I just wanted to add one thing, that many a times it's the stress factor which also plays a role in this. And so if you have seen, if you give a break for these couples for a few months, quite a few come back with a positive pregnancy test, especially the one with unexplained infertility.
Yeah, that's very, very true. And I even tell them it's very difficult for them to take off from work, especially all these IT people and all that. Business and IT, they are the two sectors which cannot take off. And they are on different schedules, night duty, and one is on night duty, one is on day duty. All those kinds of things have to be counseled, and we must try corrections. But definitely taking a break for 2 months or something, people do come back, as you rightly said that.
So this guidelines also says that there is no need to do and ovarian reserve testing even by an ordinary ultrasound. It doesn't make a difference in the management. So I had my doubts in that. What do you say about it, ma'am?
Yeah, I too looked at that. And of course, we are worried when we see a young woman having only two antral follicles on either side. And one of the basis of doing the ovarian reserve test is to advance their treatment. If their ovarian reserve is low, she's already, on the lower side, lower centile. And there's no point in saying, no, it's okay. I think that point we may differ.
So again, here also we need to look at everything from Indian context. So we are coming across so many young women with low ovarian reserve. And just because she's 28 years of age does not mean that she may be having a normal ovarian reserve. So again, we have to take it in the Indian context. And if we have come across or we are coming across such kind of scenarios, we should be going ahead and doing it. Probably we should be putting these things on paper, and maybe we can give our data to them, present to them, and tell that it might be tweaked a little bit for our own country.
So this is what I want to tell, like, people who are practicing OG, we should do our own scans, have a look at the if not an AMH or if not an FSH or an estradiol, at least an AFC count, and tell them, look, you can do an IUI 3 cycles, better not go up to 6, and after that take some decision, accelerated treatment. Now, another point, they have been going on saying about HSG with oil-based contrast. Have you ever seen in India anybody doing using oil-based media? So, ma'am, you have been abroad. So,
very funny. It was not even a HSG, Mona. They were talking about flushing the tubes with the thing. So, what's it? I mean, there's no. I don't know how that came into a.
Why did they put it up? So I went through sir, have you seen people do oil-based media, HSGs?
No.
Yeah. So actually, I went through that article which they have quoted of 2020, wherein 1,000 people were evaluated with this HSG, and ultimately in the discussion they said that the insurance company favors to use the costly contrast media of oil-based because there is a 3 to 5% chance of spontaneous pregnancy. So they save their money.
That will save their money.
Their money on ART.
So that happens even with a water-soluble contrast, right?
Yes.
We do see a lot of pregnancies after a plain
that is why. So
contrast.
that also doesn't stand good. Like, oil-based media, they have gone on saying.
Ma'am, actually, there is a question in the chat box, if I can ask that.
Yeah.
So, said, is there a role for your postcoital test? Because sometimes a couple come and tell you that they have consummated, but we don't know whether they are really consummated or not, because most of them, even if they work in the IT, they don't even know whether, it's a penetrative sex or not. And one of the doctors commented that is one of the way where you can just take a sample, just make sure, the coitus has happened or not, this be of role.
I would, ma'am, can you answer this? Or what my personal experience is that if we do a good vaginal examination and a good history, that part can be taken care of. We don't have to do a PCT. Yes, but certain cases where they say, in spite of, introitus being tight, they say they are having normal relationship, they are having normal contact. In those cases, we can do a postcoital test just to make sure that they're having normal contact and tell them, like, look, actually you're not ejaculating and actually you're not penetrating. So only not routinely indicated.
Absolutely.
Not routinely indicated.
Yeah, postcoital test has been, of course, for a long time, it has been.
Ma'am,
something wrong with the system. Just a minute. Sorry. So for a long time, they've taken the postcoital test out of the list. Mostly, I think it's a very difficult thing to time it and, do it that the logistics are different, for number one. Number two, as even if you find the sperm, you don't know really whether it's gone in, after full penetration. That also is there. And so they've taken it out. And as Dr. Mona rightly pointed out, a thorough history taking and examination will tell us whether the coitus is taking place.
So, you want to, that one more question is there, what is the role of endometrial factor in unexplained infertility? So,
Yeah,
sir?
as we said already, that the oocyte and the sperm quality, genetics, the fertilization, and the implantation. There comes in the endometrial factor. Not only the health of the endometrium, the window of implantation also comes into play. So definitely endometrium has a big role here.
Yeah, but then evaluating the endometrium at this point where it's an unexplained infertility, I don't think it is necessary to take a biopsy and evaluate. Maybe an ultrasound-based evaluation would be enough
Yeah,
to
you
say the
don't need a
pattern, to
biopsy
say
anymore.
the thickness. I think
Yes.
we have an ultrasound, a good ultrasound in the
Exactly.
mid-follicular phase would tell us that the endometrium is excellent, not echogenic,
If you
no
have,
polyps,
if
and
you
you
have a
don't
good trilaminar endometrium, good
Yeah.
thickness, the blood flow is good,
Yeah.
and the uterine artery PI is also good.
We
I
don't
don't
require.
think that you need to do an invasive, endometrial
Receptivity array.
evaluation.
Okay, so is there a role for chlamydia testing? There is another question in the chat box.
I think it just adds to the cost. The tubes are paid. Well,
Yeah.
So again, chlamydial, in our country, we see more of tuberculosis than chlamydial infections. So maybe it would be wiser for us to do a tuberculosis testing than doing a chlamydial testing.
So now we have like farmers giving us a lot of mixtures of, like fertility protection mixtures. So what is your comment on that? Including a probiotic from the start of the cycle, throughout the cycle, at the time of implantation, at the type of ovulation. Then they give you nitric oxide donors for just like that, not even thin endometrium. For everybody routinely, they say these are studies, they just bring that in your consultation room and say that. So anyone want to comment on that? All these, whatever the farmer brings into you.
I think we should practice only evidence-based medicine.
Perfect.
Right?
Perfect.
Whatever the farmer says, whatever they claim, we have to go by evidence. And that's the point of this journal club, I think.
Yes,
True.
absolutely, absolutely true.
So actually, this article has said that there is no role for any of these boosters, adjuvants which are given. Okay. And advanced testing also are not required to say that she is unexplained. That's the main point here.
The only thing is what we need to consider here as well is all the publications which come here. One should look who has sponsored that study.
True.
See, ultimately everything is pharma driven.
There'll be a conflict of interest in all those.
So at the end of the day, we have to see what happens is many times we don't look into these small prints which are there. We just
Conflict of
the
interest.
paper and we believe what they have come up with. So we need to have a holistic approach when we actually read the paper.
Yes, sir. Thank you.
Thank you.
See, even the WHO, criteria for semen analysis, that itself, after so much of research and data gathering, that itself is under question. So where are all the other things like your...
True. Because, actually, whatever the WHO cutoff is there, it's the 5th centile of what is normal.
Yeah.
And we tell them that, see, your parameters are within the cutoff level. The male partner comes and says, see, I'm perfectly normal. The problem is with the female partner, she's not conceiving. He never believes that he's the 5th centile and not in the 50th. So we get issues there.
So the other
as
side
Madam said, yeah, the working of WHO was even questioned during the pandemic.
Yeah. The flip side of that semen analysis report is, even if there is a slight, reduction in motility or an abnormal sperm count, I mean, the normality is only 2%, it just batters the male, I think we should sort of counsel them very carefully when we see an abnormal semen report. Tell them what the WHO is. It's given us a broad outline, not a diagnosis on you. And because it just, it shatters the male patient. That also we have to think of.
Yes, we have both extremes.
Yeah, both extremes, right?
I think there's a last question there.
There is
Thanks.
a
Role.
question. Yeah.
Yes, sir.
Role of empirical ATT. If you ask me, there is no role of empirical ATT. You have to have a tissue diagnosis before you start with something which is going to be, which might be hepatotoxic, which has to be taken for 6 months. So somewhere you need to have an evidence. Again, as Madam said, that we are in the era of evidence-based medicine. So without evidence, it's my opinion. Ultimately, there could be difference of opinions here as well. But my opinion is, until and unless you have a tissue diagnosis, we should not start with it.
Exactly, precisely, because it is such a toxic therapy. It is hepatotoxic. You can die because of an ATT. So you need to have we need to be we need to have solid evidence to say that there is a mycobacterium there and I have to treat it. No empirical.
Other than hepatotoxic, also sometimes they may have severe joint pain, hyperuricemic. These are like really, their morbidity for the patient during the ATT will be very bad. The patient herself will feel very bad. Some may not tolerate at all. We had few episodes like we had to taper down the drug, stop it, then restart it one by one to give it to them and make sure she tolerated. So those are.
There have been case reports of deaths due to ATT, even in the city of Chennai. There was long back. There was a lot of things went on the newspaper and all that. So we have to be very, very careful. I mean, I also rope in the pulmonologist who's very well versed with ATT regarding the newer schedules, regarding the toxicity. So have them on board.
Yes, true. I had a patient, madam, recently. She had a scanty flow for 1.5 years, a patient of infertility for 3 years, but scanty flow, and every time her endometrium was thin. But she gave a history that one of the endocrinologists treated her as hormonal problem, and he saw it improved. But I gave her first cycle of induction, ovulation induction, then we added gonadotropin, then we gave her even with complete estrogen. The endometrium was persistently only maximum 4.5. Then we went ahead with hysteroscopy. Thankfully, she agreed, and there were granulomatous holes were there in the hysteroscopy. It was like totally fibrous, nothing was there, and scan showed water pockets within the endometrium. And the same areas we were finding granules, like it was looking like pustule pockets, madam, on hysteroscopy. And then we came out, we sent it for gene expert, but the gene expert came out to be negative. It was negative for TB. So again, the confusion was there. So we involved the physician. But they said with the history that she has scanty flow and seeing a granuloma in hysteroscopy, and so these two are good enough. And the biopsy came back as a granulomatous lesion to consider FOGSI. So these three are enough. So even if the gene expert is negative, you can start on ATT. So we started her. So sometimes at least
granulomatous lesion is evidence enough. With the white cell ratios, with that itself you can start. You don't need to find a mycobacterium there. Probably that's the only instance you can do it without the mycobacterium.
Yes. So even like when we are doing, if you don't even do a hysteroscopy, when you do a biopsy, make sure you send it for gene expert and the histopathology, so that your histopathology will pick up these granulomatous lesions. So ma'am, is there anything else or any other thing you want to add on? There is one more question. Do we have to give endometrium for AFB culture? No, nowadays we use only gene expert. No, madam, I don't think they are doing the cultures because it takes around 2 to 3 weeks, and gene expert has more sensitivity than
with these platforms. You don't need a culture.
Yes. So I think there are no more questions, madam. So thank you, Dr. Kanavi, madam, and Dr. Mona, madam. It was such a wonderful discussion, and congratulations to your postgraduate. Like, she really did a very good job concising the guidelines, giving us what it was there, and always comparing it to the other guidelines and the previous what recommendations was there. Excellent presentation, and also congratulations from the team from the Triple M with Dr. Geeta as a moderator. So very good take-home points on whether you have to do single versus double. And thank you, Dr. Chaitanya sir and Kannagi madam, for being the expert. Very good take-home points. I feel like everybody has, like, received their take-home points when they want to go home now. So thank you everyone. Thank you for joining us, madam. Thank you.
Thanks. It was
Thank
our
you for the
pleasure.
opportunity.
Kind invitation.
Thank you for the opportunity.
A wonderful journal club. Nice.
Thank you, sir. Thank you.
Thank you,
Thank you.
sir.
Thank
So
you.
keep it up, Deepa. Please continue the journal club and we'll be
Yes,
joining
ma'am.
in.
Ma'am?
Yeah.
We are conducting it every second Tuesday of every month, madam. So each month we have selected a topic, and it is a FOGSI. We have like joint hand with Dr. Sureka Tyagde. So FOGSI with
congratulations.
every month we are doing, madam.
Excellent effort.
And once the recording is there, we will share it